Welcome to Alta California Regional Center's Program Design Workshop for Client Services, Behavior Intervention and Consultation, and Emergency Intervention. This is being brought to you by ACRC clinical staff. This presentation is intended to provide information as well as guidance in developing specific components of your program design, which are indicated here. To begin, let's discuss types of regional center services. Traditionally, regional centers offer both supportive and therapeutic types of services. Supportive services are goods and services that maintain an individual's health and safety and/or provide assistance with their care and supervision needs. Whereas therapeutic services are outcomes-based services that aim to improve an individual's independence with critical life skills and/or reduce challenging behaviors that pose a risk to health and safety or interfere with daily functioning. Now take a moment in thinking about the type of service you plan to provide. Which category do you fall into? Do you provide supportive services or therapeutic services? To guide your thought process further, you may consider that if you plan to help the individuals you serve to meet goals for increasing independence or reduce challenging behavior, you would fall into the therapeutic category. As residential service providers, of course, there is a supportive component, as you are also providing for the care and supervision of the individual. But there is also a therapeutic or outcomes-based component. Now, how does this relate to your program design? Your program design details all of the following in relation to the services that you provide. It details the what. For example, what is the type of service you plan to provide? For whom? What is the overall vision and mission of your program or service? And what outcomes do you hope to achieve? It also details the how. How do you plan to achieve these goals and objectives? What specific tools, methods, and materials will be used for assessment, goal development, skills teaching, and behavior management? And in this presentation, we will primarily be focusing on guidance for depicting your how. Your program design will also detail the who. Who are the people that will be providing the services? What are their qualifications? What prior experience, education, and training do they have in relation to the methods that you plan to use or the people you intend to serve? To further lay some foundation, let's discuss some basic expectations for regional center therapeutic services. Regional center services are intended to be person-centered, meaning that the person served remains at the forefront of the goals and objectives of the service. You, as a provider, will solicit input from the people that you serve on what they would like to achieve and incorporate that into your treatment planning. Services must also be provided by individuals qualified to provide the service. For example, do the individuals providing the service have the relevant experience, education, and training required for that position? This also extends to professional third-party consultants. Regional center therapeutic services should result in meaningful progress for the individual. As a provider, it's your responsibility to demonstrate that the service is resulting in increased independence and a greater quality of life. Regional center services cannot fund services that provide no evidence of their efficacy. And finally, regional center therapeutic services must be evidence-based. The methods used to teach skills and reduce challenging behaviors must be vetted by high-quality research. And regional centers cannot purchase experimental therapies and services. Now, what do we mean by evidence-based practices? If this is a new term for you, you will want to know that evidence-based practices are scientific, they're high quality, and they're reliable at their core. This means that to be an evidence-based practice, there has to have been high quality research that has demonstrated its efficacy on more than one occasion with more than one individual. We use evidence-based practices and promote their use first and foremost because it is a legal requirement in the Welfare and Institutions Code, but also because it has a higher chance for success for the individual to gain the desired skills and to reduce any challenging behavior. Evidence-based practices are supported by research, and they are also best practice for most therapeutic intervention fields of practice. So, what are these evidence-based practices? How do we know if a practice we're using has evidence to support its use? In 2020, the National Clearinghouse on Autism Evidence and Practice released their most recent publication on evidence-based practices. This report includes research from 2012 to 2017 and is combined with their prior 2014 publication, which included research from 1990 to 2011. The current report identified 28 evidence-based practices as well as 9 manualized programs. And those have been listed here. Some of these may be familiar to you. For example, you may see on the right-hand side prompting and reinforcement, which are commonly used in the developmental services sector. On the left-hand side, you will also see the 9 manualized programs, including Picture Exchange Communication System, Pivotal Response Training, and more. For further description of each of the practices, the National Clearinghouse offers this matrix that includes a basic definition of each of the 28 evidence-based practices. Now, in terms of how to apply evidence-based practices, they may not be useful to teach every skill or manage every behavior for every individual across the age. How they are efficacious and best used are going to be specific to skill domains as well as the age ranges that they're effective for. The National Clearinghouse offers us guidance through this colored matrix that has on the left-hand side vertically a column with all of the evidence-based practices, and then horizontally across the top, the different skill domains that they can be used to address, which have been broken up into 3 age range categories. The 0 to 5 age range is depicted in the yellow box. The 6 to 14 is depicted by blue, and the 15 to 22 is depicted by green. How to read this, for example, is if I look at the very first practice, ABI, or antecedent-based interventions, and I look to the very first row next to it, the academic or pre-academic skill domain, I can see that all 3 age ranges have been colored in. This would mean that antecedent-based interventions can be effective for teaching academic or pre-academic skills across the age ranges. In addition to the National Clearinghouse on Autism Evidence and Practice, there are several other national authorities on evidence-based practices. These are listed here: the National Professional Development Center, the National Autism Center, as well as the National Technical Assistance Center on Transition. All of these and more can be found on the CAPTAIN website, which is a statewide network of autism professionals who host a free website with links to many EBP resources. And that website address is found here. Client services, categories of function, provision of services, and reporting on progress. In your program design, you will be asked to indicate which skill domain areas you will provide teaching or training for. The different options are listed here: training in personal hygiene, dressing skills, motor skills, toileting, mealtime, communication, training in independent living, social skills, rec and leisure skills, and community integration. Within each of these general skill domains, you will have a number of additional skills. For example, training in personal hygiene may include such skills as oral hygiene, such as brushing teeth, flossing, using mouthwash, and accessing dental services. Training in personal hygiene may also include bathing and showering, which also include a number of skills to be taught. Shaving, feminine hygiene. What you are going to do in your program design is check the boxes for only the skills that you plan to provide teaching or training for. In terms of determining which skills you plan to teach, here are several factors for consideration. You may want to think about your resident demographics. For example, do the skills relate to the profile of resident you plan to serve? The type and the level of service. For example, does providing teaching and training in the skill area relate to the overall vision and mission of the service that you plan to provide? Staff education and training. Do you and your staff have adequate education and training in the practices needed to teach the skills? For example, sign language. This is not a skill that many staff commonly come with. So you may want to consider not teaching adult sign language or American Sign Language if your staff do not have any education or training in that model of communication. You may want to consider what other resources that you have access to or plan to offer, such as, do you plan to partner with other specialists, such as a behavior consultant, who may have the relevant education and training needed to address the skill area? Your program design should include a detailed description of how you plan to assess resident skills across skill domain areas. Information to include would be how you plan to gather the information. Do you plan to do record reviews, personal reviews, or interviews? Observations? Do you plan to probe specific skills? It should also include which tools, materials, and resources you plan to use. Are you going to use a validated assessment tool, such as the Adaptive Behavior Assessment Scale? Do you plan to use specific materials to test skills? And what resources Inform your assessment procedures. You will also indicate who will conduct your assessments. Who are the people involved, including any professional consultants. You will also indicate timelines for completion of assessments. Within what time frame can we expect that different assessments will be completed? For example, perhaps the initial screening assessment will be completed in 1 to 2 days or 1 week, whereas a complete skills assessment may take 2 to 4 weeks. You will also want to include how you plan to use the information collected during assessment. How does that information inform your treatment planning? Next, you will include skills, teaching, and training components. For each category of function, you will provide a narrative description of the following: the services provided that will enhance the capabilities of residents that may have severe self-help deficits, mobility impairments, disruptive behaviors, and/or self-injurious behaviors. Include who will provide the service as well as who will oversee the service, providing any technical assistance or training on service implementation. You will also indicate which instructional methods to use. These are going to be the specific teaching strategies you plan to use to teach skills in the specific category outlined. Please only include evidence-based practices for skills teaching that are appropriate for both the skill domain addressed and your demographic served. Please do include any tools, materials, and/or resources you plan to use or that inform your teaching and training plans, including any curricula or manualized interventions. And finally, methodology for measuring progress. Please provide in your program design a detailed description of how you plan to measure resident progress toward individual service plan goals across skill domains, to include the types of data to be collected, your data collection systems. For example, are these going to be paper, online systems? How will they be accessed? Frequency of data collection, the positions or roles responsible for this data collection, the positions and the roles responsible for review of accuracy of data collection and frequency of checks, the positions and roles responsible for reviewing efficacy of teaching plans, and your methods and intervals for summarizing and reporting data, including person responsible for reports that are provided and when. Next, you will provide 2 examples of skills teaching plans and their corresponding data collection forms. These teaching plans should incorporate the use of evidence-based practices and be general in nature that can be modified if needed to meet individual needs. The evidence-based practices used should be appropriate for the skill area being taught and age of the residents being served. Data collection forms should include a space to include the date, the resident's name, and staff name or initials, in addition to the teaching procedure to be used, step-by-step instructions for staff implementation, as well as prompting and error correction procedures to be used. Okay, now, if all of this talk about evidence-based practices, prompting procedures, error correction procedures has you kind of in a tailspin, here's a good place to start. A lot of individuals, unless they have a behavioral background, are not as familiar with each of those practices and exactly how to implement them. Luckily, we have a wonderful resource, and that is the Autism Focused Intervention Resources and Modules, or AFFIRM, which has a virtual learning module for 27 of the evidence-based practices, as well as modules for paraprofessionals and how to go about selecting evidence-based practices and others. Please visit the AFFIRM website and view any modules that may be helpful to you in providing effective evidence-based practice services. In addition to regional center requirements, the Center for Medicaid Services, in their final rule, also has a few requirements. One of those being that licensed care providers must solicit resident input on various aspects of service delivery through hosting weekly resident meetings. Please detail in your program design your plan for the following during these weekly meetings: your meeting procedures, including when and where meetings will be held, who attends, who facilitates these meetings, and how you plan to ensure all resident input is obtained in the event that an individual refuses to participate, cannot attend a meeting, or is nonverbal or non-speaking. You also want to share how information is gathered. Provide a description of the type of information you plan to gather during the weekly meetings, as indicated in the CMS final rule, such as resident values, preferences for food or menu options, and daily schedule of activities. And then you will want to indicate the documentation. What are your procedures for how to document your weekly meetings, including who documents the meetings, what information is documented, and where the documentation is stored? Please also provide a sample copy of the form to be completed during your weekly meetings. Behavior intervention and consultation in licensed residential facilities. In this section, you will provide a narrative description that includes your philosophy of the overall approach on addressing challenging behaviors, as well as provide resources that inform that approach. Share your rationale for providing intervention support and services during both short and long-term outcomes that you hope to achieve. Include specific strategies the home plans to use that provides evidence of your philosophy and approach. Describe strategies that may be used for both individual behavior management as well as group behavior management. Also, provide information on the general strategies within the facility. Include a detailed description of how you plan to set up the home to prevent challenging behavior, mitigate risk for injury during challenging behavior, support independence, and encourage positive behavior. Also, detail the protocol staff will be trained to use to respond to challenging behavior until a formal behavior plan is developed. And finally, behavior consultation. Include a description of that service that you plan to provide. For example, the behavior consultation, what that includes, and consider the role of the consultant and their involvement from pre-admission screening to initial resident assessment, ongoing behavior management support, as well as any transitional supports. Methodology for measurement. Please provide a description of how you plan to measure resident progress toward goals related to the reduction of challenging behavior and increase in replacement skills. Include the following: types of data to be collected, data collection systems, frequency of data collection, the positions and roles responsible for data collection, how staff will be trained on data collection, the positions and roles responsible for review of accuracy of data collection and frequency of checks, the positions and roles responsible for reviewing efficacy of teaching plans and behavior intervention plans, your methods and intervals for summarizing and reporting data, including person responsible. For example, what reports are provided and when, and provide samples of data collection forms that staff will be routinely trained to use. Please also include 2 sample data forms for 2 behaviors from the accepted behavior checklist that you plan to use. Be sure your forms comply with Title 17, Section 56013D. Now, who is qualified to provide behavior consultation? You have 2 primary options here. You have either a board certified behavior analyst or BCBA, or you can contract with a behavior management consultant. As you can see here, the primary difference in these 2 different professionals is that the board certified behavior analyst has a master's in applied behavior analysis, psychology, or related field, and also holds a national certification in ABA through the Behavior Analyst Certification Board. Whereas the behavior management consultant may be a licensed psychologist, marriage and family therapist, clinical social worker, or like trained individual that also has 12 semester units in ABA that they have completed at a collegiate level, and 2 years prior experience in the design and implementation of behavior intervention services. If you plan to contract with a group practice or agency for your behavior consultation, you will first want to determine who is the either BCBA or BMC, behavior management consultant, that will oversee a bachelor's level staff. In terms of who is qualified at the bachelor's level, under the BCBA, you have the board certified assistant behavior analyst or BCABA, and this person would have a BA or BS in ABA, psychology or related field, and also holds a national certification in behavior analysis through the Behavior Analyst Certification Board. Under the behavior management consultant, you may have a behavior management assistant, and this person would have a bachelor's level and 12 units of ABA and 1 year of experience in designing behavior services, or 2 years experience designing and implementing behavior modification services, or is registered as a psychological assistant or associate licensed clinical social worker. Your options again are to contract with a sole provider or an agency. However, if you contract with an agency, you will want to ensure that the person under the BCBA or BMC meets these qualifications. In terms of your program design, you will want to outline both the qualifications of any consultant in your home and include for review the following for anyone providing behavior consultation services in your home: a resume, proof of clinical licensure or BCBA certification, and for behavior management consultants, you will also provide collegiate transcripts showing 12 semester units of ABA. Now, what does a behavior consultant do? Regional centers expect that behavior consultants will do the following: conduct a functional behavior assessment for any individual residing in your home within the first 30 days of admission, and provide a written functional behavior assessment and behavior intervention plan within 60 days. Behavior consultants conduct assessments, for example, skills assessments, restraint risk assessments, and otherwise. They develop the behavior intervention plan within 60 days of admission for each client and train staff to implement each individual's behavior plan within 90 days of admission. Your behavior consultant will likely develop and provide you with data collection forms as well as procedures, provide both assessment and update reports quarterly for residential, semi-annually for day programs, as well as collaborate or work with other service providers, professionals, and the resident circle of support to ensure consistency of behavior planning across individuals and environments. Keep this list in mind when you are contracting with your third-party consultant to ensure that they will be able to fulfill these requirements. In your program design, if you plan to contract with a group practice, you will want to show what the division of responsibilities in terms of service hours will look like for your program. This is one example. For example, on the left-hand side, you see a list of different tasks or job duties. And then in the two next columns, you see how this may look for the division of responsibility across the supervisory level professional. And then in the next column on the right-hand side, the hours that may be conducted by that bachelor's level staff. And then on the far right, what the total hours are. In terms of evidence-based practices for challenging behavior, it looks a little bit different than how we may select an evidence-based practice for skills teaching. For example, when addressing challenging behavior, while there are a number of strategies that can be effective, in order to determine which of those strategies to use or which collection of strategies to use, your consultant must always start by conducting a functional behavior assessment, which is also one of the evidence-based practices. The process should look something like this. Your behavior consultant will conduct their functional behavior assessment by doing observations and conducting interviews with individuals that know the resident well. This is done to try to determine why the behavior is occurring. Once that step is completed, then a function-based behavior intervention plan will be developed by your behavior consultant. This will include a combination of some of the evidence-based practice strategies that will hopefully prevent problem behavior, teach replacement skills, and reinforce behavior change. All behavior plans must include evidence-based practices within these 4 categories: your preventative procedures, teaching procedures, reinforcement procedures, as well as consequence interventions. As a part of your program design, you will provide a sample functional behavior assessment and behavior intervention plan. This should be authored by the consultant or consulting agency you plan to work with, and it should include all necessary information as outlined in Alta Regional California's service standards for behavior consultation in residential facilities. That outline will include these 14 content areas: identifying background information, the functional behavior assessment information, a definition of each of the behaviors of concern, baseline rates of behavior, antecedents or setting events, past consequences, hypothesized function of behavior, replacement and related skills to teach, preventatives, teaching and reinforcement procedures, consequence procedures, goals, data, as well as a brief summary with recommendations. For the complete outline and description of each of these content areas, please see our service standards for behavior consultation in our licensed residential facilities. This can be found on the Alta California Regional Center website under the provider forms. A note about recommendations. It is the expectation that the recommended hours for behavior consultation be based and determined on individual need. Please talk to your assigned community services specialist about your options in the event that the recommended hours exceed what you can accommodate reasonably within your program. Your responsibilities in partnering with your behavior consultant are indicated here. You will want to ensure that your consultants meet minimum qualifications, that they provide any assessments and update reports within the timeline indicated in service standards, ensure that they're conducting functional behavior assessments and developing behavior intervention plans, and include all necessary information, as well as ensure your consultant provides the minimum direct service hours as required. Ensure that your consultant provides update reports, as well as implement the behavior plan and teaching plans, and provide staff all the necessary materials and training to implement the strategies indicated in the plans. You will also need to ensure that all your consultant hours and supervision hours have been documented, and ensure that staff complete special incident reports, post-restraint reports, and shared information reports as needed. In terms of tracking behavior consultation, to ensure that the relevant information is collected to be verified, you will want to use this document. This behavior consultation log can also be found on Alta's website under the Provider Forms Residential Provider section. Emergency intervention plans. In this section, we will be covering the basics of crisis intervention, what is needing to be detailed in an emergency intervention plan, as well as Title 17 requirements for the use of behavior modification procedures that may cause pain or trauma. Up to this point, what we have discussed is behavior consultation services that are standard and fall in alignment with best practices for the practice of applied behavior analysis. However, sometimes those strategies are not enough to prevent the occurrence of dangerous behavior. So when behavior plans fail and dangerous behaviors have erupted. We have to figure out what the plan and procedure will be to maintain resident safety, and this may include crisis or emergency interventions. Now, what do we mean by crisis? Crisis behavior can also be referred to as an assault cycle, which may include a period of escalation, yelling, screaming, pacing, maybe AWOLing, usually resulting in an assault or attempts to assault and or serious injury to the individual or others. And it's typically followed by a period of de-escalation, which may appear similar to the escalation. Again, yelling, screaming, pacing, and typically ends with a post-crisis depression. During this phase, the individual may cry, apologize, fall asleep before returning back to their baseline or their normal behavior. This assault cycle representation is based on the Professional Assault Crisis Training Manual developed in 2013. When we respond to crisis, it's important to know that it may be different or contradictory even to a behavior analytic approach. The reason for this is that resident safety always comes first. All staff should receive training on a curriculum-based program that offers certification in how to respond to a crisis. Some examples are listed here: PROACT or Professional Assault Crisis Training, Nonviolent Crisis Intervention through the Crisis Prevention Institute, UCARU, and others may be considered on an individual basis. Some considerations for selecting a curriculum or crisis intervention program. In order to maintain individuals' rights and to do no harm, we need to see that the curriculum focuses on safety, dignity, and respect of the individual, and that an emphasis is placed on communication and de-escalation rather than restrictive or controlling types of interventions. It should also include utilizing interventions in a least to most restrictiveness way regarding the hierarchy of interventions. It should focus on escaping and evading assault or crisis behavior versus controlling crisis behavior. And in the event that physical intervention is needed, use procedures that do not intentionally cause harm, such as through the use of pressure points or painful positioning to subdue an individual. Physical restraint. Physical restraint is the use of a manual hold to restrict freedom of movement of all or part of a person's body, or to restrict normal access to a person's body, and it's used as a behavioral restraint. It is any staff-to-person physical contact in which the person unwillingly participates that also restricts movement. Physical restraint does not include briefly holding a person without undue force in order to either calm, comfort, or brief physical contact intended to gently assist a person in performing tasks or to guide or assist a person from one area to another. These definitions are provided to us within the Health and Safety Code, Section 1180.1, located in Senate Bill 130. There are, however, limitations on the use of physical restraint. Regional center providers may only use physical restraint under very specific provisions as outlined under Title 17 regulations, Title 22 regulations, as well as the Health and Safety Code. And it's important to note that restraint may only be used in an emergency intervention plan as outlined in your program design. Emergency intervention plans, the Title 22 regulations, Health and Safety Code, and requirements for your program design. Title 22 regulations provide a significant amount of guidance in terms of what needs to be included in an emergency intervention plan. It's important to note, however, that this distinction is made at the very forefront of the emergency intervention plan section. And this statement indicates that applicants or licensees shall be responsible to ensure that an emergency intervention plan is developed and approved by the department prior to the use of manual restraint or seclusion if staff use or it is reasonably foreseeable that staff will use these techniques. In taking another moment of reflection, based on the type of service that you plan to provide and the possible behaviors of the clients that you may serve and potential risk to health and safety, do you reasonably foresee a need for you or your staff to use manual restraint or seclusion? If you are here and you are taking this presentation, the answer is most likely yes. If you plan to accept individuals with a high degree of self-injury or assaultive behavior, that behavior carries with it a risk of serious injury. So then what needs to be in the emergency intervention plan in your program design? This emergency intervention plan is designed in conjunction with a behavior management consultant or BCBA and is a part of your program design. The emergency intervention plan is your written plan addressing the prevention of injury and implementation of emergency intervention techniques. And it includes the following: assessment procedures, for example, restraint risk assessment, needs assessment, as well as the tools and the timelines used for these assessments. Rationale for using emergency interventions, a description of the continuum of interventions from least to most restrictive as outlined in your crisis curriculum, as well as when to contact emergency services, descriptions of all restrictive interventions, including time limits, procedures for monitoring, procedures for maintaining safety of all residents during a crisis, procedures for reviewing and modifying plans, as well as staff qualifications and training requirements. In your program design, you will want to detail your assessment and pre-admission requirements. The Health and Safety Code requires all licensed facilities complete a restraint risk assessment prior to admission. Obtain the client's documented advance directive on the use of restraint and seclusion. And the facility emergency intervention plan must be reviewed and consented to prior to a client's admission. For more information on these components, please review the emergency intervention program requirements as outlined in Title 22. It is important to note that the client demonstrates an imminent risk of serious injury when there is a chance for significant impairment of the physical condition as determined by a qualified medical personnel and includes, but is not limited to, burns, lacerations, bone fractures, substantial hematoma, or injuries to internal organs. And it is only when the client demonstrates a risk of this serious injury to themselves or others that physical restraint is ever warranted. You will want to indicate this specifically in your program design. You will also need to indicate your awareness of emergency intervention prohibitions, which include the use of mechanical or chemical restraints, such as straitjackets, posy ties, the use of adverse behavior modifications, such as body shaking, water spraying, slapping, pinching, using strong ammonia vapors, sensory deprivation and electric shock, using pain to control behavior, such as putting someone in a headlock, using pressure points, finger bending, joint extensions. Any procedures that may block airway or restrict breathing, including items that may cover the face, and then manual restraint beyond 15 minutes without the additional required permissions. In addition, you will want to indicate in your program design your awareness that restraint may not be used and will not be used for staff convenience, as part of a treatment program, in lieu of using behavior intervention services, if it would worsen a pre-existing medical condition, or due to the client's medical condition place the client's life at risk. In your program design within your emergency intervention plan, you will want to describe the continuum of interventions from least to most restrictive. Include criteria that indicates the need to use crisis interventions as opposed to your traditional behavior interventions, as well as criteria for contacting emergency services. It's important that crisis procedures described should only include those that are included in your selected crisis curriculum. When describing the restrictive interventions, be sure to include procedures for hold initiation and team communication, procedures for monitoring safety during any holds, procedures for ensuring safety of all residents during a crisis, as well as timelines for holds and additional authorizations needed to extend beyond those timelines. Your program design will include a description of your post-restraint procedures. In this section, you will provide a narrative description of the processes and procedures for the following after a restraint has occurred. 1, reintegration of the resident into the setting with others. 2, debriefing procedures. 3, review and modification of the behavior plan. And 4, notification to required parties, including the types of forms and timelines for submission. Please include the following documentation and reporting requirements, including when to provide special incident reports, as well as post-restraint reports, debriefing meeting documentation, monthly restraint logs, as well as your internal 6-month restraint review. And you will also need to indicate in your emergency intervention plan the staff training requirements, which must include a minimum of 16 hours of a standard curriculum-based program within 30 days of hire. Certification verifying staff's successful completion of training, minimally 6 hours of crisis intervention refresher training annually, which is provided by an individual who has valid instructor certification in the selected program. And this is typically going to be the administrator, as well as documentation of this training, which must be maintained in personnel records. Now, moving on to the individual emergency intervention plans. This is where we use the previously discussed framework of the facility's general emergency intervention plan to create a plan that has been specifically tailored to an individual. You can think of your general emergency intervention plan as an umbrella term, which then can be tailored for the needs of each individual, which then results in an individual emergency intervention plan. Here are some differences. The emergency intervention plan, detailed on the left-hand side, is in your facility plan of operation or your program design, and indicates your general process for responding to any client in crisis. It specifies the continuum of interventions based on the selected curriculum, the staff that are able to implement these procedures for ensuring care and supervision of other clients, criteria for contacting emergency services, and this must be agreed upon during admission. Whereas the individual emergency intervention plan on the right-hand side is developed when a facility reasonably foresees the need to use restrictive interventions with an individual. This must provide a specific individual plan for each client. It will include de-escalation procedures that do not require manual restraint. It will include the description of the restraint procedures that are okay to use with the individual based on their individual factors and advance directive. And this must be consented to prior to implementation. The individual emergency intervention plan can either be an extension of the client's behavior intervention plan or its own separate document. This will detail the procedures to use after the procedures in the behavior plan have been attempted and failed or are insufficient to ensure safety. Individual emergency intervention plans must be approved by ACRC's Behavior Modification Review Committee prior to implementation. In this section, we will discuss the Title 17 regulations for the review process by ACRC's Behavior Modification Review Committee, which reviews any potential procedures that may cause pain or trauma to an individual served. Examples of behavior modification procedures that may cause pain or trauma include physical restraint, mechanical restraint, as well as chemical restraint. What you will note is that chemical restraint is never utilized in residential care facilities, as it is only acceptable to be utilized in hospital settings where a physician oversees the procedure. Prohibited behavior modification procedures that may cause pain or trauma also include the use of seclusion, which is the involuntary confinement of a person alone in a room or an area from which the person is physically prevented from leaving, as well as some punishment procedures such as the introduction of aversives like water spraying, yelling loudly, or say putting hot sauce in someone's mouth for saying a bad word. So really what we're talking about is only the review potentially of physical restraint. And a little more information on that as it pertains to Alta Regional in general is some statistics are included here, such as In 2018, there were 242 incidents reported to Alta California Regional Center. We share this information with you so that you can see that the need for restraint does, in fact, occur. And these incidents are likely an underreporting as they only reflect individuals served that live outside of their family home, which is representative of only around 20% of the clients that we serve. Restraint may also be referred to as a protective hold or a handle with care protocol. So it's important to know that the term restraint may not always be used, while the procedure being used may in fact be a physical restraint. Restraint is only to be implemented by individuals who are trained in restraint procedures, because it does always carry a risk of injury, even when conducted appropriately. In a review that the Crisis Prevention Institute did on 63 restraint deaths, they found that 57 were actually implemented correctly. So you can see that the vast majority of the time, even if the restraint is carried out correctly, it can still cause risk of severe injury or death. Restraint does not include the use of protective or physically supportive equipment, such as a gait belt to be utilized for postural support and or postural supports as needed to hold an individual up, say in a seated position in a wheelchair. And it's important to note that restraint should never be the only procedure or only plan in place, because it's merely a safety mechanism and it is not a therapeutic intervention. Some additional important information to know is that clients at the age of 15 and older per the Lanterman Act have the right to refuse any procedure that may cause pain or trauma, including the use of restraint. So if you are a provider of children, this is important to know for you. And also Title 17 does require that we conduct an in-depth interdisciplinary review before restraint or another potentially harmful procedure is implemented with our clients. There are a number of risks and side effects associated with restraint. We touched on restraints can result in death, but even if not death, restraint can result in physical pain, including redness, lesions, bruising, disjointed limbs, broken bones, restricted circulation, positional asphyxia, cardiac arrest, death, emotional trauma or re-triggering of past traumas. It can also result in sleep disturbances, incontinence, decreased appetite. And this risk does increase if the individual has co-occurring medical conditions that place them at greater risk, such as asthma, obesity, low bone density, and more. So because of these factors, regional centers consider restraint and any potentially harmful procedures to be ones that require close review and monitoring. So whenever a potentially harmful procedure may need to be used with a client, these are the following steps that must be taken by the team to ensure that regulatory and best practice guidelines are met and that the individual's rights are protected. The first 3 steps depicted here is simply planning team discussion of the need for a plan that includes restraint, interim safety planning. This is where the team will meet to discuss possible ways to mitigate risk and need for restrictive interventions. There will be a preliminary procedure review where an ACRC clinician will review the provider's plan that includes restraint to ensure that it includes all necessary content as required by regulations. Following this step will be the team's review of the plan together and obtaining of informed consent to use the plan. The informed consent must be written and must include a description of both the benefits and risks of using the restraint procedure. Consent must be obtained by any unconserved adult consumer and or circle of support or supported decision makers in their life. Next will come the client's physician's authorization. In this step, the physician is not required to review and approve the restraint protocol. Rather, the physician is required to provide a statement that indicates that he has medically ruled the procedure out to be safe and that it's not going to exacerbate a co-occurring or pre-existing medical condition, and that medical intervention is not the needed course of action to address the behavior of concern. Once those two statements are signed and the physician has indicated in writing that those statements are true, then we can take all of that information and have it reviewed by the ACRC Behavior Modification Review Committee. The client service coordinator will present the procedure and all supporting documents for the committee's approval in this step. Ongoing, all update reports will be reviewed by an ACRC behavior analyst. We will document the outcome of that BMRC review in the client's IPP, as well as any future reviews and outcomes. And each occurrence thereafter must be documented in a special incident report, post-restraint report, including a debriefing record. All of this should be included in the description of your emergency intervention plan procedures in your program design. Thank you. You can direct any questions, comments, or concerns regarding the content of this presentation to your assigned community services specialist, who can connect with our clinical team to provide you a response. Thank you.